Okay, let's jump right in. Welcome to this explainer on postpartum physiology and complications. We are going to unpack exactly how to distinguish expected, normal healing from a life-threatening emergency. If you're prepping for the clinical floor or the NCLEX, this is your ultimate guide to answering one massive question. What physiological changes should you actually expect after birth?
We've got a lot of ground to cover. Here's our roadmap. We'll start with a bubbly assessment model, move into uterine involution and lochia, hit systemic adaptations, then cover breasts, bladder, and bowels. Finally, we'll look at spotting postpartum emergencies and tackle that classic NCLEX normal versus abnormal distinction. Section 1, the bubbly less assessment model. So to do a systematic assessment, we need a really reliable roadmap. Enter the bubbly mnemonic. It keeps your assessment super organized from head to toe. We're talking breasts, uterus, bladder, bowels, lochia, episiotomy or lacerations, lower extremities, and emotions. Honestly, following this exact order ensures you don't miss a single vital system during those incredibly critical first few days. Section 2, the reproductive core. Let's look at the most dramatic physical shift, starting right at the center. It's honestly fascinating to see how a healthy, firm midline uterus physically shrinks back down into the pelvis day by day. We call this involution. Right after birth, that fundus is right there, easily palpable, but it normally descends about 1 centimeter or roughly 1 finger breadth every single day. By week 2, you shouldn't even be able to feel it abdominally anymore. And just as the uterus drops, the expected vaginal discharge, which we call lochia, follows a really predictable chronological timeline. Visually, this progression tells a story of how the inner uterine wall is healing. You expect the flow to gradually lighten up in both color and volume. Days 1 to 3, that's Lochia rubra, a dark red. Days 4 to 10, it shifts to Lochia serosa, which is more of a pinkish brown. And finally, from day 10 all the way up to 6 weeks, you'll see Lochia alba, which is white or yellowish. But here's the so what. You have to know your red flags. A decreasing flow is totally normal, right? But what if you see a sudden return to heavy, bright red rubra, or your patient saturates a whole pad in just 1 hour, or maybe the uterus is enlarged, high up, and just not descending? That completely flips the script from expected healing to a dangerous emergency, usually pointing to retained placental tissue or subinvolution. Section 3, systemic adaptations. Stepping back from the reproductive core, let's talk about hemodilution. The body goes through profound fluid shifts after birth. Understanding this helps explain why a pulse of, say, 50 or 60 beats per minute with a stable respiratory rate might be perfectly expected early on. But, and this is a big but, sudden tachycardia paired with falling blood pressure, pallor, and low oxygen? No way. That is an immediate red flag for postpartum shock and hemorrhage. It's the same deal with the white blood cell count. It is actually completely normal, what we call physiologic leukocytosis, to see an elevated WBC up to 20,000 or even 30,000. Sounds crazy, right? But the tone totally shifts to an emergency if you see that high count paired with a fever over 100.4 degrees after the first 24 hours, uterine tenderness, or foul-smelling Lochia. That's your classic presentation of endometritis. Now, patients get really worried about visible changes to their bodies, so we have to be ready to reassure them. Things like pelvic floor weakness, diastasis recti, which is the separation of abdominal muscles, stretch marks, fading of pregnancy pigmentation, and even temporary hair loss. All completely expected physiological adaptations. Knowing this allows you to provide some really great client education and much needed peace of mind. Section 4, breasts, bladder, and bowels. First up, the bladder. While intense sweating and diuresis are just the body's way of dumping all that excess pregnancy fluid, you have to watch urinary output like a hawk. Frequent small voids, pain with urination, or a uterus that is pushed way over to the right side, those urgently warn you about urinary retention. And this matters because a full bladder literally physically blocks the uterus from contracting, which can rapidly trigger a hemorrhage. Moving to the bowels. Look, it's super common for a patient to not poop for 3 to 4 days. Decreased peristalsis, hemorrhoids, fear of tearing, it all contributes. That's expected, so we just promote fluids, fiber, and walking around. But if you have absent bowel sounds coupled with severe, uncontrolled pain and a distended belly, you need to escalate that immediately because you might be dealing with an obstruction or a paralytic ileus. For the breasts, as colostrum shifts to mature milk around day 3 or 4, temporary bilateral engorgement and tenderness are entirely expected. Both sides will be sore. But if a patient shows up with a unilateral, meaning just one-sided, hot, red, swollen, hard area on the breast, plus a fever and flu-like symptoms, you've got the complication of mastitis on your hands, and you need to act.
Section 5, Spotting Postpartum Emergencies. This is the critical climax right here. The root causes of postpartum hemorrhage are beautifully categorized into the 4 T's. Whenever you see a hemorrhage, which we define as blood lost over 1,000 milliliters or showing signs of hypovolemia, your brain should immediately run through these 4 categories as your rapid diagnostic tool. You definitely want to memorize these clinical shortcuts. Tone is the big one, causing 70% of cases. A boggy uterus means uterine atony. Trauma is 20%. If the uterus is perfectly firm but bright red blood is just pouring out, suspect a laceration. Tissue is 10%. A high uterus with prolonged rubra points to retained placental fragments. And finally, thrombin is 1%. If you see diffuse oozing from IV sites, you're dealing with a critical coagulation issue like DIC.
Because uterine atony is the most common culprit, let's hammer this home. If you encounter a boggy uterus, your absolute first priority is to aggressively massage the fundus to stimulate contraction, help empty that bladder, and call for help. You do not leave the patient. You act on the ABCs right then and there. Section 6, NCLEX, normal versus abnormal.
Let's simulate the clinical floor. General swelling, or edema, in the lower extremities is a totally normal finding after all those fluid shifts. But what if a patient complains of one hot, red, swollen, and tender leg? That unilateral pain is a deep vein thrombosis, or DVT. And the golden rule here? Never, ever massage it. You could easily dislodge the clot and cause a pulmonary embolism. Just notify the provider immediately.
Okay, rapid recall time. Imagine this scenario happening right in front of you. You walk into the room, pull back the blanket, and see heavy, rapid bleeding with clots. You palpate the abdomen, and the uterus is soft and boggy. What is the very first clinical judgment you make to save this patient? You immediately provide fundal massage, you make sure the bladder gets emptied, and you call the rapid response team for IV fluids and uterotonic meds. You're fixing tone. But here's the thing, as an exceptional future nurse, you must always think one step ahead. What's your next move if that first intervention fails? If the fundus firms up but the bleeding won't stop, are you ready to look for trauma? Keep asking yourself these questions, lean on your BUBLE assessment, and you'll be ready for absolutely anything the postpartum period throws your way.